The worst thing about pharmaceutical agents like semaglutide and tirzepatide is that we are not able to prescribe them to you on the first onset of insulin resistance. We have these medications that could quite literally save your life, and yet they tell us that we have to wait until you are obese, diabetic, or damn near your deathbed before we do anything about it.
Dr. Jones, are we able to accomplish our goals without the weightlifting? Just a little difficult for me.
So you absolutely can achieve short-term weight loss because these medications, you know how powerful they are at suppressing your appetite, but you're not here for short-term weight loss. You've already told me how many times you've lost weight only to regain it back. You're here because you want lasting weight loss, and I'm gonna get you there. So trust me when I say this, resistance training has to happen. We're gonna implement it, but don't worry, I'm here to guide you, and the community here is to support you. We'll figure out a way that you can adhere and sustain to a resistance training program. Okay? All right, we'll see you on the next coaching call. If you guys haven't heard of these powerful GLP-1 medications like semaglutide or tirzepatide, or maybe you have but you're afraid to use them, then we need to flip the script. We need to change the rhetoric because there's so much misinformation floating around about these medications. Trust me when I say this, I continue to pour through all the literature that comes out regarding these medications, and these are the most powerful tools that we had, not just for obesity and diabetes. No, these are metabolic health improving. And if you ask me, the basis of the majority of our health issues and diseases start with metabolic health issues. And so we're gonna clear up all the confusion, we're gonna clear up all the crap in this video and talk about why these medications are so powerful and exactly everything you need to know about them. So the reason why you guys should listen to me is because I have clinics that service across the nation, helping our patients. I work with our medical practitioners achieve lasting weight loss. And we've been doing this for the last 20 years, specifically the last 5 to 6 years with GLP-1 medications. And I'm all in, baby. I'm in for GLP-1 medications. I think they allow such a larger pool of people to be able to finally get through that initial barrier where nothing would have worked otherwise. But what I've been able to accomplish is because my passion has always been more of a holistic, natural approach. And when I see what's going on, and we're going to dive into all of this with these medications, is the people that are not happy with the results, the people that are getting the severe side effects, the people that are losing all their muscle mass, they're not doing it right. You have to get lifestyle choices in specifically, and there's so many of them, and we're going to cover all of them near the end of this video. Resistance training being a really big one. These medications can actually help you put on muscle mass if you use them correctly. But unfortunately, for many reasons that we're going to get into, many people are not using them correctly. And this is why a lot of them are not getting ideal results. But despite being used horribly incorrectly, we still have a surge. We still have excitement. We still have explosion because for a lot of people, they are still working. Wouldn't you want to be one of those people that are doing this right and getting the best results possible? Well, let's help you get there. Okay, so I don't know how many of you guys are big South Park lovers. I've been watching South Park for as long as I can remember, but specifically these last several years, they've gotten to this movie mode because the producers and writers of these videos of South Park they're just geniuses. And they did a clip on Ozempic and GLP-1 medications. So let me share this little 45-second clip because I think it plays into what we're going to go over here. I hope you guys can have a sense of humor there. If you've never seen South Park, maybe you find that offensive, but hopefully you know this is a parody and a make fun of all the issues that are going on right now. And we're not going to get into all of them, but specifically we are going to talk about GLP-1 medications because just like the doctor said, these are a miracle. And when we look at the options that we've had in front of us and the tools that we've been working with in terms of weight loss medications and just everything out there in general, even outside of the bucket of weight loss medications, nothing has ever came close to the power that these medications have. And it's such a shame that they're demonized, ostracized, picked on. People are bullied and picked on and made fun of for using these medications. And there's just so much shame along with it. And it's an even bigger problem that it's only being sort of an option to be considered when a person reaches full-blown obesity or full-blown diabetes. And we're going to get into all that. But what the hell? The path down these disease progression could have been prevented significantly sooner. And the potential need for all these other medications could have been alleviated with the potential use of GLP-1s earlier. But this is one of the many problems that exist. But despite all that, I want to educate you guys on these medications. So let's take a step back and let's actually discuss lasting weight loss just as a whole, not even looking at these medications. I want to show you guys this study here, but what they looked at was the success and lack of thereof of success for people to actually maintain weight loss. And the data is very clear. Like, it just doesn't happen. Over 85% of people who have ever embarked on a weight loss journey and actually successfully lost more than 10% of their body weight, they fail to keep it off within a couple years, 2 to 3 usually. So that is significant. And I'd argue and bet that the majority of people, if you ask them and pull them off the street, what percentage do you think people are actually successful long-term? They'd probably guess it's more than 15. But when you hear such a staggering statistic, and you look at the population right now, and you look at the world, and the way obesity is trending, as you can see here on this graphic, 4 decades of rising obesity, and there's so many videos I've made talking about why the trend specifically started in the 1970s, and basically, long story short, the government made a big change in our dietary approaches and told us to stop eating as much fat and saturated fat, and therefore carbohydrate consumption dramatically increased, and a lot of that was processed carbohydrates because we had exposure to that, and now we look at the rates of obesity, and now we're paying the price. So it's real stuff. It's scary, actually, when you look at how staggering obesity is and the problems that arise. I mean, when you work in healthcare and you deal with metabolic issues and you help people with optimal health, wellness, lasting weight loss, you begin to realize that at the core of all these diseases is insulin resistance, chronically elevated insulin levels. I would put inflammation up there too as well. And they're at this point, very, very nuanced, intense conversation comparing and contrasting the two. But at the base, for the sake of this video, we have to fix the insulin resistance, which causes us to lower our chronically elevated insulin levels, and we have to decrease inflammation. It's the combination of both of those alongside some genetics and lifestyle factors that put people down this path to develop all sorts of comorbidities and various issues, cardiovascular disease, cancer, cholesterol issues, which lead to their own issues like heart attacks and strokes, neurodegenerative diseases, which, by the way, if you haven't heard, some people are starting to refer to Alzheimer's as type 3 diabetes. Okay. Not everybody has jumped on that and accepted that yet. And I'm certainly not a neurologist or a neuroscientist myself, but understanding the reasoning behind why some people are making that classification, and just personally dealing with lasting weight loss for the last 20 years and seeing how many other issues get better. Oh my gosh, like when we help people not just lose weight, because I've done them both. Remember, my history before I became a doctor of chiropractic and opened up these medically integrated practices and helping people clinically lose weight, I managed gyms, and we had 20 personal trainers, hundreds of people working with our personal trainers. And so managing all that. And at that time, I mean, this is before fasting ever really took off. It was the old school calorie approach, calories in versus calories out. We got these people to count their calories. We got them working out in a resistance training program. We got them doing cardiovascular to burn calories, eating less, eating better food, 4 to 6 meals a day, and it works. Like, that method still works. In fact, that's what I did. That's what I did when I lost 100 pounds myself over 20 years ago. And, unfortunately for me, I failed to keep the weight off, right? I didn't understand metabolic health. I didn't realize that there's other things in the background, specifically hormones, that are creating signals towards our bodies that are influencing how we respond to a caloric deficit or a caloric surplus. But that's the reality. And we're starting to understand that with the popularity and explosion of these medications. So there's so many directions I can go with all that, but I want to keep us on track because the goal of today's video is to educate you on everything about GLP-1 medications. But I think we are starting to realize that obesity is a disease, that it's not a result of calories. And this whole rhetoric of calories in versus calories out. I have a ton of other videos. Check out this video here as well if you want to look at the difference between calories and hormones. I take a deep dive into that, so you guys can check that one out later. But regardless of whether we call it obesity, right? Because this isn't just obesity, because even the definition of obesity is kind of silly, right? BMI over 30. Well, what about women with PCOS? What about women when they hit menopause? What about any gender that develops an autoimmune disease? What do we see in all these conditions? We also see a load of insulin resistance and then a lot of variability from there. But when we look at all these conditions, right, what's the common denominator? Well, clinical presentation that's keeping them overweight, keeping them sick is that food chatter, right? That appetite that they're always hungry, we're always pondering and reaching for more food, that very intrinsic drive, and these medications just obliterate that. I mean, it's just amazing. We're going to get into all that. But what these medications do, right, is they cause that weight loss. But aside from these medications, looking at all these various conditions, right, that all have food chatter, the final nail in the coffin, if you will, is weight maintenance resistance. I say this term a lot. There's resistance to maintaining a weight that was just achieved after weight loss, right? So weight loss maintenance resistance, weight maintenance resistance, but that is the bigger problem. I already shared with you the statistic earlier, backed up by research, that 85% of people will fail to maintain their weight loss. I mean, you drop a comment and let me know on this video, how many times have you lost weight only to regain it? How many times? I bet you need at least 2 hands to count. Most of us have. So yours truly, because I told you I lost weight myself, the old school method with the calorie approach, I struggled for over a decade, losing weight, regaining it, losing it, regaining it. And I just thought that's the way it's going to be for the rest of my life. I knew how to lose the weight and it required a crap load of effort. I just couldn't do it for the rest of my life. It was just too much. And so anyways, you guys check out that video I mentioned earlier. You'll learn a lot more about it. So when I look at these medications, these are a miracle. They really are the miracle solution that we've been waiting for, that we needed, because why we got here, how we got here. I mentioned the change in our consumption of food dramatically mandated by the government, but there's so much more to this. And that's going to be saved for many other videos. Besides genetics, there's lifestyle. And then I also think that we have a really high amount of toxic exposure, forever chemicals, yada, yada, yada. So we need this miracle solution. This miracle solution is in front of us, and we call them GLP-1 medications. So let's get into some of the science. I won't bore you guys too much. I just want to kind of get a base of it, and then we'll go on to more practical information. What are GLP-1 medications, right? Well, we have to understand what the incretin hormone system is, okay? So we have these incretin hormones that are released in reaction to the food that we intake, right? So we eat food, the food passes through our gut, and there's a release of these various hormones. And there's a few of them. They regulate fullness and they regulate blood sugar. So we have mainly the GLP and the GIP, okay? So the GLP hormones are made by the L cells in the lower gut, and specifically they enhance that beta cell function of the pancreas. Essentially, the pancreas is the gland in our body responsible for making insulin, which is that main hormone that regulates our blood sugar. And beta cells is one of the main cells that actually produces the insulin that we need. And so GLP-1 enhances the release of insulin. GIP is actually made by the K cells in the upper gut, and they will also enhance insulin secretion. Right. We'll get more into the differences between those two types of incretin hormones later. But it was actually an interesting discovery on how they figured this out. But there's a difference in terms of oral consumption of sugar, glucose, versus IV administration. There's a significant increase in blood sugar rise, much higher with an IV exposure versus oral of the same amount. Right. And so what they discovered upon that discovery afterwards was, oh my gosh, there's these hormones that get released only when stuff is consumed orally and passes through the gut. And these hormones have so many different areas of the body that they act on, right? So one area, and I think this is probably the most powerful effect that these medications do, it's up there with the improvement of insulin resistance, but they literally act on satiety centers in the hypothalamus. Right. So the hypothalamus is sort of the main regulatory center of your brain. Think of it like a relay station, and it is detecting a lot of various hormones in your body so that it can then give a signal to the rest of the body to produce this or to not produce this, produce more, produce less, because it's detecting and reacting, right? That's what the hypothalamus does. One of the various aspects that the hypothalamus controls is satiety, fullness, hunger, right? Because it wants to achieve an ideal balance for you in terms of how much food you eat, right? So GLP-1 and GIP stimulation will affect the hypothalamus in the brain to promote fullness, Some also cool discoveries have been made recently on GIP and its ability to actually promote better fat burning, which is one of the many reasons I like tirzepatide. And we're going to talk about the difference in the medications here in a little bit. So we talked about effects on insulin, right? They're going to do two things. They're going to increase the release of insulin, but they're also going to make you more insulin sensitive. This, I think, is the primary function. This I look at as the most powerful thing that these medications do, because when we say we are going to, the effect of improving insulin sensitivity is the same thing as decreasing insulin resistance. So we have to understand that, because I know it can be confusing. A lot of us hear the term insulin resistance, but maybe don't hear as much insulin sensitivity. It's essentially saying the same thing, but they're opposite, right? So we've heard this term insulin resistance, which is a condition that refers to your body's sort of resistance to the effects of insulin, right? And insulin's job is to lower blood sugar. So now your body has to release more insulin to get the job done. That's what insulin resistance is. So when we say we are decreasing insulin resistance, not only are we saying we are less resistant to insulin, but we are also, that is synonymous with saying we are more insulin sensitive. I just wanted to clarify that, because I know sometimes that throws people through a loop. Are we talking about a different process when we hear sensitization? No, it's just sort of a different way of saying the same thing. Okay, so another hormone that's worth mentioning is glucagon. So glucagon raises blood sugar via a process called gluconeogenesis and glucogenolysis. And so gluconeogenesis is the creation of glucose from other substrates like amino acids, for example, and glucogenolysis is the process of cleaving down the stored sugar, which we refer to as glycogen. So glucogenolysis, breaking that down, getting glucose. So what glucagon has its own roles and what stimulates it and what doesn't, but guess what GLP and GIP does? GLP will reduce the effect of glucagon. And this is actually something that makes that new class of medication, retatrutide, that much more special. And we're going to talk about that later. So another powerful effect of these medications is slowing down of the gastric emptying. And this is important because when you think about the transit of food through your GI tract, simply taking longer to move will keep you full longer. There are mechanical receptors, sort of pressure receptors, if you will, in the GI tract that will respond with fullness just in the presence of something there. And so this is another entire powerful effect. And then the net effect between that and the effect on our brain means we have severe appetite suppression. But then again, we have that paired with decreasing insulin resistance. And now I've explained to you that insulin resistance, in my opinion, paired with inflammation, is the center of almost all these diseases. Like the majority of the diseases that plague us start with some sort of insulin resistance decrease in metabolic health pathway. So GLP-1 medications have actually been out for a while, right? So Ozempic, semaglutide, that's the first one that got big. But the first medication, exenatide, was a game changer for diabetes management. This was such a powerful option because prior to that, this was the only option was insulin, right? And this is not the ideal solution to handling a diabetic because remember, chronically elevated insulin levels lead to insulin resistance. And when you have a patient start injecting insulin to get the job done of lowering blood sugar, you are now creating more insulin resistance. And so this was a big deal because now patients that were on insulin were in many cases, being able to actually wean off the insulin and replace it for a medication, which promotes the opposite direction. Instead of more insulin resistance, it actually promotes less insulin resistance. This is massive because the literature, when we look at comorbidities of diabetes, like specifically cardiovascular disease, we see levels of cardiovascular disease not even being any better in diabetic patients who have quote unquote managed blood sugar levels when they're on all these medications. And so this is where the trend, and we're starting to realize, yes, we know the dangers of rising blood sugars, but we're not really seeing people get much more healthy when they have controlled blood sugars because the majority of the diabetic medications are just shoving more glucose into the cells. They are creating more resistance. And so we have to get ourselves out of this tunnel, right? This hamster wheel that's rolling down a hill. We need to roll up. And there's going to be resistance along that path. But when we can get to the top, we can get out of this hole, we can handle this issue and restore optimal health. And so having a medication for diabetes was a big deal that can do this, but it didn't really do much for weight loss. Then we had our first approved GLP-1 for obesity, liraglutide or Saxenda. The results were so-so, but for that time, there was still a lot of excitement. There was still a lot of popularity, but it did not blow up the way it did until semaglutide rolled around. So I love this graph here because it just kind of makes it easier for you guys to think with all the different names out there. So let's clarify all this. So we're talking about, and let's ignore retatrutide right now because retatrutide is not even FDA approved. So semaglutide and tirzepatide, we have two compounds, right? So semaglutide is made by a pharmaceutical company known as Novo Nordisk, and they were actually FDA approved for diabetes, and they called it Ozempic. This was back in 2017. Then same medication, semaglutide, right? Same chemical, but then it was FDA approved for obesity, and they called it Wegovy. I know. Why do they do that? Why do they give it a whole different name and make you think it's a whole different medication when the whole time it's not? It's just the way they do it. And honestly, I have no clue why. So tirzepatide is a second chemical, right? Made by a company called Eli Lilly. And this is more powerful. This is the upgrade of semaglutide. Semaglutide works on the GLP receptors only. Tirzepatide not only works on the GLP, but it also works on the GIP. So the data is actually very clear on tirzepatide. Not only does it get better results, better weight loss, but it also gets a lower side effect profile, which is awesome because we always want to have less side effects when we're using a medication, right? So tirzepatide has the same sort of situation going on like semaglutide. It's got two different names for two different conditions, same ones. So Mounjaro, FDA approved for diabetes, and Zepbound, which was actually just recently, a little bit over a year ago, approved for obesity. So again, we only have two compounds we're talking about, semaglutide and tirzepatide. And if you can get your hands on tirzepatide, I would recommend that, as it is a much better option. But I wouldn't poo-poo semaglutide. I wouldn't poo-poo any weight loss medication. If you are looking to restore optimal health and lose weight, we just got to use it as a tool and pair it with lifestyle choices. But yes, my favorite and best approach would include tirzepatide if possible. Now, I'm talking about retatrutide only because it's not FDA approved, but we have people out there using it. Now, you might be asking, how the hell are they using it? They're getting their hands on chemicals from research companies. And if you guys want to learn about research companies, you can not only check out my video here called Peptide 101, but you can also listen to Andrew Huberman's recent YouTube video that he released, his podcast about peptides. Go to the section here. It's like one of the first chapters there in that first 10, 15 minutes where he talks about the dangers and concerns with getting these peptides, getting these medications from research companies. There's no regulation. They're overseas. The quality is low. So not only is concern number one that you're not actually getting a quality product, but number two, the concerns of contaminants, specifically LPSs, lipopolysaccharides. And so please be safe. Please be careful. Retatrutide is not anywhere close to being available from compounding pharmacies, let alone pharmaceutical options. And I just want you guys to stay safe. Okay, so I like this graphic here as well. How does tirzepatide work? So we talked about this, right? When we consume food, we get it into our intestine, specifically the small intestine first. Food triggers naturally that GIP and GLP-1 stimulation, right? And that works on the brain. That works on the pancreas. That works on fat tissue. So we have that decrease in appetite. We have that less drive. It's easier to eat better. It's easier to make better choices. We lose weight, right? We become more insulin sensitive. We decrease insulin resistance. And we have a real shot here at implementing proper lifestyle choices and getting the results that we need, getting the results that we desire to stay motivated, right? That's a whole nother piece of the mental piece of it, is some people just can't even get into a rhythm, into a groove because they can't get results. The medications can be your tool for that. But also ensuring that we don't fall off track is one powerful aspect of these medications because they affect the brain and the impact is huge. I wanted to interrupt for a quick minute and let you guys know about the permanent weight loss guide that I've created for you guys. I'll link to it in the description. It
covers 3 of the most common roadblocks that people encounter on their weight loss journeys. Number 1, weight loss plateaus, how to bust through them. Number 2, how to start a prolonged fasting regimen, but do it safely and do it correctly to optimize results. And then finally, medication independence, specifically semaglutide tirzepatide. If you're looking to save the most amount of money, this guide and this program will help you wean off of it. I'll link to it again at the end of the video here in the notes. And now back to the show. So again, I want to just lay out the receptors just so we're clear. So semaglutide stimulates GLP-1 receptors. Tirzepatide hits the GLP and the GIP. And then retatrutide, when that one eventually comes out, is going to be affecting the GLP, the GIP, and it'll reduce glucagon levels, which reducing glucagon levels is a good thing for what we're trying to accomplish with these medications. Okay, so there's a ton of data out there to show you how effective these medications are at losing weight. And I don't think like anybody is arguing that. Like I don't need to prove to you guys these medications work for weight loss. I think the virality of them sort of speaks for themselves. And there's no other medication that comes close to this. I would say phentermine, which has been our tried and true weight loss medication. Decades it's been out, and for decades, we have decades full of literature, and the side effects suck. And a lot of people can't even use them due to cardiovascular concerns. But not only do these GLPs give you better appetite suppression, but they don't have nearly as bad of a rap in terms of the negative consequences. So again, miracle tools, miracle drugs. If you can get your hands on them, if you are struggling with lasting weight loss, you absolutely need to. Don't worry, we're going to get into all the misinformation and bullshit that people are saying when they don't know what the hell they're talking about. So there's so many other benefits. And this is why I get so excited, because I published my book. It's available on Amazon, and I'm waiting to see somebody kind of try to do the same thing that we're doing here. And I want to give a shout out to Dr. Tina. I just caught wind of her podcast. I actually reached out because I think what she's doing great. What she's doing is great, and her approach and philosophy sort of mirrors mine. But so I'd love to get with her and connect with what we're doing. But many clinics are not providing the coaching and the support and the guidance to help people implement the right lifestyle choices alongside these meds. But my gosh, when you pour through the literature, right, the benefits are just so much more than weight loss, so much more than lowering blood sugar levels and diabetes management. Oh my gosh. We have I'll show you guys a study right here, neurodegeneration, right? It's protective against neurodegenerative and being researched and looked at as a possible solution for neurodegenerative diseases, which again, type 3 diabetes, this medication helps diabetes. It would make sense, right? That also kind of proves the point that Alzheimer's is the type 3 diabetes is a good name, right? But cardiovascular disease improvement, addiction issues, fatty liver disease, kidney disease. I mean, the list goes on and on. And yes, I did say addiction. They are literally looking at these medications as a possible solution for addiction. And if you're on these medications, you could probably relate to that, because we see it all the time. People telling me, oh my gosh, like I don't feel the urge to drink as much. So it's not just a food chatter thing. It's a lifestyle chatter, right? A chatter, an urge to do things that aren't good for us, like smoking, like drinking, like not exercising, like prioritizing the things that we know aren't good for us. These medications can really dampen that effect in the brain, because remember we talked about it, they work on the hypothalamus and provide us that result, that desired effect that we need to get things going. Okay, so let's clear up the bullshit. Let's clear up the misinformation out there. My gosh, I mean, I would say the biggest, you go on TikTok, for example, and you're scrolling and you see people selling various weight loss alternatives to GLP-1, and they're trying to say crazy things like, for example, berberine is as good as GLP-1s, or the Unimate tea stimulates GLP-1, misleading people to thinking, oh, GLP-1, if I could take this tea and spend just as much as I would on the medication, it's going to give me the same effect. Like, oh my gosh, look, I want to be clear right now. I'm not saying 100% of people should do these medications. I'm not giving you medical advice. You need to talk to your primary care physicians and make the best decision for yourself. But where my passion comes from working in weight loss over 20 years, from my own personal struggles, it comes from the fact that I think even just being 10, 15, 20 pounds overweight, I know how quickly that can turn into 30, 40, 50. this pathway of insulin resistance and poor metabolic health, leading to high blood pressure, high cholesterol, diabetes, and potentially ending up on all these other medications and just screwing up our metabolic health and overall health and quality of life, could have been all prevented how we got our shit together from the beginning. And a small dose of these GLP-1s could be the necessary ticket to get people to help them get their shit together. So anyways, that's my viewpoint. And I just wanted to make sure I'm clear with that. All right. So, oh my gosh. All right. So number one, these medications do not cause cancer. All right. Yes, there's a label on the box, and you have to understand when you look at the research, these were very rare types of thyroid medullary carcinomas in rodents. So it was very rare, and it was in rodents. So they have to put that on because they have not got to a point where they can prove that it doesn't. And I understand and respect that. But there's actually been some data afterwards starting to trend in the other direction that it is very likely not going to be. I think we're going to get to a point where they're going to be able to remove that is what I'm trying to say. So you still shouldn't use these though if you have a family history of thyroid cancer, just to be safe. But that's what it is right there. A family history of a specific type of thyroid cancer. So we're talking about a very narrow bucket. And to be safe, don't use them, but that's very different than they cause cancer. And when I hear people say idiotic and moronic things, they should be freaking booted off social media, because that's just completely false information and very scary to hear. A lot of people are going to hear that and just run away, walk away from this potentially life-changing miracle drug. That's the solution that they need. So pancreas and gallbladder. Okay. So the pancreas and the gallbladder can get a little overworked with these medications. And we've seen it. I've seen maybe 4 or 5 patients out of thousands have an elevation of their pancreatic enzymes. And we're very thorough. We check our patients every 3 to 6 months, recheck their pancreatic enzymes, and teach them to take the appropriate actions if they ever feel low back pain or feel very nauseous, any of the sort of symptoms that you might get in an acute pancreatitis situation. So the actual statistics of pancreatitis are extremely, extremely low. Same thing with stomach paralysis, gastroparesis. These are short-term complications. And how do we know it's not an effect of where the person's at their initial health level, right? That's another thing that we have to consider too as well. So you shouldn't start these medications if you do have active pancreatitis. If you have active gallbladder issues right now, I think we got to get our health in order a little bit and then potentially start these medications. The only other real contraindication is being on a bunch of other diabetic lowering medications, especially insulin. Because if you are, right, then it now becomes a matter of diabetes management, which needs to be prescribed carefully by your diabetic provider, whoever that is. But we're talking about non-diabetics right now. And so for non-diabetics, you really wouldn't be on other diabetic lowering medications, hopefully. So maybe just one, maybe metformin, because you're pre-diabetic. That's where we find millions of people right now who are obese and pre-diabetic and trending towards that path. So this is how you get out of it, folks. We get out of it with these medications and then implementing proper lifestyle choices afterwards. Okay, so what are the real side effects? Like, what can we actually expect? All right, we got 3 categories. And I'll tell you, nausea is the main one, right? And then some people get some diarrhea and some people vomit. Okay. I think this is happening because a lot of people are starting off on higher doses, or they're not freaking waiting enough time to titrate their dose up. Remember, in my opinion, these medications are being horribly misused. They're not being used to their fullest potential, I guess, is really what I'm trying to say. How could they? I don't want to go down too far down a tangent here, but practitioners are paid so little nowadays by insurance companies, and they have such a little amount of time. How could they get into any lifestyle intervention? So it's really not the doctor's fault. It's just freaking the entire system is screwed up. But anyways, so the actual side effects we're talking about: nausea, diarrhea, and vomiting, right? And the one that I would say I've seen in probably half of patients is some amount of nausea. Well, if you don't rush to increase the dose, you are going to less likely experience these or experience a lower amount of them. And then number 2, like, what's the approach here, right? I've talked to so many people out there who are almost just excited to increase their dose, right? Because, like, why not? And I can understand and appreciate from a patient's perspective. I want to see what it feels like to go on a higher dose, but I did a separate video talking about this, the dangers of too much appetite suppression. You can check it out right here. But for us, like me, so in my clinic, I do the coaching and my medical practitioners do the prescription. So it's a great combination. And so we're all on the same page here. The best dose for our patients and our programs is the lowest dose that allows them to implement the lifestyle choices. That's the ideal dose. It's not just this arbitrary path of increasing. And I'm not saying doctors are telling patients to go as high as they want. I mean, the general approach is increase till we're in a good range of weight loss. That's the approach. But what if we can use the combination of the medication with the lifestyle to achieve an ideal weight loss rate? That's important. That's powerful. That's what we do. And that's what, unfortunately, I think not enough physicians and clinics are doing anything close to that, right? And there's so many clinics popping up right now offering these medications, and they don't even have a platform for coaching, right? So anyways, I don't want to go down too far that hole. So what about muscle loss? Okay. So this is a big deal, and I think it's worth talking about, especially Peter Attia. If you guys don't know him, I have a lot of respect for him. When he came out and mentioned so much muscle loss happening, I think it really added to the fuel to the fire, right? Fuel to the agenda here of misinformation and scare tactics regarding these medications. But here's the reality. These medications improve insulin sensitivity. They decrease insulin resistance. They decrease inflammation. That is the background scenario of what you want to enhance muscle growth. They actually put your body into a better environment for muscular growth, hormonally speaking. But hormones are not the only variable that we have to consider with growing muscle or losing muscle. In fact, even more important than hormones is calories, right? And we're all fat, overweight, the majority of us, and so we need to eat less. But without structure and coaching and guidance, how much less? The medications are suppressing my appetite too much, so I don't even know how much to eat. No one's telling me. How do I approach this? I just kind of roll with it, which for some people, my God, I have some people coming to us and we start working with them and get them counting their calories. And after we ask them, I ask this question all the time, like, once they can count calories, how much do you think you've been averaging? And you wouldn't believe it, but I have patients, and this is regularly, that have been on these medications for 3 months or more. I've been averaging about 800, 900 calories, and I feel fine. Of course, you feel fine because you're not hungry because you're on this medication. But when we dig deep into this, right? We dig deep into this and we find out that they're tired, they're brain foggy, they have lower energy. They actually don't feel good, but they feel good because they're skinny. They lost weight. And I think the excitement of that can easily override the actual tiredness and energy and brain fog. And so it's pretty amazing. I feel like there's a society of zombies, if you will, that are developing, and we're going to see more and more of these as these medications, unfortunately, get utilized the way that they are. And I'm hoping that with my efforts and other doctors alike, that we can help prevent that from happening. But I guess zombies would be better than a bunch of obese, sick, and dying people. Take that for what it is. So muscle loss, you have to resistance train. You have to absolutely lose weight. If you're not resistance training, if you're not lifting weights, if you're not getting adequate protein intake, these are the two most important lifestyle aspects for protecting muscle loss. Remember, when you go on a weight loss journey, right, you're always going to lose a certain amount of muscle. And the goal is losing the least amount of muscle in ratio to the total amount of weight loss. And the two things that are going to improve the ratio, right? Decreasing the amount of muscle loss and have the total percentage of weight loss be more fat loss is resistance training during the weight loss program, like a solid, steady, foundation-based approach towards weightlifting. This is like many things we coach our patients with, and then consuming adequate protein. What about Ozempic face? What about Ozempic butt? These are real conditions, right? And this is happening, right? Ozempic face and butt is happening. I'm not saying it's not happening, but just like muscle loss, we know why it's happening, right? These people are not, they're malnourished. If you lose weight, we have to take a step back and go, what is the medication doing to these people? It's producing massive and rapid weight loss, right? And in most cases, we don't want to lose rapidly, although in some cases I would argue it might be worth it. But in most cases, we don't want to lose rapidly. And we also don't want to do it without the lifestyle things that we're just starting to kind of get into, like resistance training. And so I truthfully think that Ozempic face and Ozempic butt is just a situation of somebody losing weight too fast, not consuming enough protein, not resistance training, and probably just not consuming enough calories, period. And now they're seeing the effects of it. We don't know yet if there's actual mechanisms happening with these medications. And I haven't seen, from all the literature that I reviewed, I haven't seen anything specifically on collagenase or any elastin or any of these mechanisms involved with our skin tightness and elasticity and youthful look. I'll definitely keep you guys posted if I learn of anything, but I think what we're seeing here is just an aspect of rapid weight loss, right? And not doing it correctly. And same thing with hair loss. Like hair loss is already a known complication and a known side effect from rapid weight loss. It's not just hair loss, folks. It's actually starts well before weight loss with decreased energy, brain fog, feeling more cold, pooping less often. What are all these things? These are hypothyroid symptoms. Thyroid gland is the main hormone that's responsible for producing the actual hormone, thyroxine, and just free T3 is how we actually measured the actual hormone itself. But this thyroid hormone hits all the cells in our body and cranks that metabolic process so that we can have energy. Okay. Well, when you have metabolic downregulation, AKA weight loss plateau, and if you guys want to learn more about weight loss plateaus, check out this video right here. It takes a deep dive into what causes this, how do we beat it, and how do we prevent it. But hair loss is actually a late stage effect of this situation. And hair loss is also just a side effect of a hypothyroid condition, however the hypothyroid condition was produced. So if we do this right, if we get the lifestyle choices in, and we're going to end this video talking briefly about them, but the resistance training, I'm a big believer in getting adequate longer rounds of fasting, eating a cleaner diet with much less processed foods, a good supplement protocol so that we can prevent any micronutrient deficiencies. And then again, big ones would be optimizing stress levels, preventing sleep issues, like optimizing our sleep, handling the stress, and then addressing inflammatory issues if we have things like autoimmune diseases or other inflammatory conditions. If we can get these basics in, which is what the medication sort of opens the door to, we're going to get the results that we all know we want and we need deep down and inside. And this is what we do every single day. And I see it on my patients when I coach them, because it's me coaching my patients in my group format, and I freaking love it. So like I was saying earlier, like, why aren't these medications the first line of defense? Oh man, I think that I'm not going to go too far down the conspiracy path here, but I do think money, like I always follow the money, folks. How many less medications would people need if upon the early development of insulin resistance? So this is well before you're even pre-diabetic, because the path towards pre-diabetes and metabolic derangement starts way back when your insulin levels start rising because of chronically elevated insulin levels. And you can check that earlier with a lab of fasted insulin or C-peptide. If we started giving patients these medications much sooner, we would see a significantly huge decrease in cholesterol medications, in diabetic medications, in blood pressure medications. I can guarantee that. But the powers that be, right? The pharmaceutical companies, the biggest ones, are the ones that make those medications. And I'm gonna leave it there. I'm not gonna say any more, but I think this is the part of the problem that's out there. I want to show you guys this study. According to this study, using data from the National Health and Nutrition Examination Survey from 1999 to 2018, the prevalence of elevated waist to hip ratio greater than 1/2 increased from 74 to 82%. 74% is already insanely high, and it's getting worse, guys. Waist to height ratio is actually way more accurate than BMI. This is central adiposity. This is central obesity. The majority of Americans are walking around with a ratio above 0.5, meaning they're all down this path of metabolic derangement and either obesity, diabetes, or many more issues. Imagine if we were doing something now. Whew. Well, this is what I'm hoping will change in the next couple of years. Okay, so let's talk compounded versus pharmaceutical brands. Let's look at this chart here again, the same chart from earlier, just so we can see here real quick. So what is the national shortage? The national shortage is the crisis that arose because they couldn't
the pharmaceutical companies couldn't meet the demand. This has happened before with other medications. And when this happens, they allow compounding pharmacies, which are not big pharmaceutical companies, but these are smaller pharmacies that are actually not regulated by the FDA, but they're regulated by state compounding pharmacies. Very different than online research companies that are not for human consumption. These compounding pharmacies are still tightly regulated. Okay. Now they're allowed to produce these. So when you're getting your compounded semaglutide, compounded tirzepatide, you're not getting Ozempic, Wegovy, Mounjaro, Zepbound. You're getting the same active ingredient from a compounding pharmacy, and whether or not they're the same thing or they're safer or they're not safer, I'm going to leave that up to you to decide. I think if you can afford the pharmaceutical brands, go for it, right? Because then we can say for sure they are safer, right? Because they do have more studies behind them. But I can tell you there's thousands of clinicians and millions of people utilizing the compounded versions. But what's going to happen when the national shortage ends is people's access to the much more affordable versions. I say much more affordable. They're still very expensive, a couple $100 a month, but much more affordable compared to $1,000 to $1,500 per month. You won't have access to those anymore. And all you will have access is the $1,000 to $1,500 a month. I don't think anybody is talking about this and even thinking with that. And I bring that up because there's a lot of people out there who just, their life changed when they started these medications. And so I can appreciate and respect that. And I can understand where the idea of like, whoa, why would I go off of that? Like people get defensive, like their emotions start to arise when you talk about taking that away from them, because this has been such a game changer for them. So I understand and appreciate and respect that. But the financial implications is just one of the main reasons why I talk about this concept of weaning off, like this concept of using them as tools so that we can make improvements in our health and then get to a point where we can decrease them and rely on the better lifestyle choices that we're making to maintain our health, to maintain an ideal body fat percentage, right? Totally possible. Just so you know, full disclosure, we've been doing this on our patients for several years. We've helped over thousands of people accomplish this, despite when you look at even the data, for example, you look at the study right here, 70% of patients who stopped semaglutide within a single year regained all their weight. So this is even faster weight rebound, weight regain than the other study I talked about, which was all kind of weight loss lumped into one, which is 85% after a couple of years. So single year. And I know with the GLP-1s, if they did further studies on this, we would see 70, 80, 90, right? The people in these studies were not being implemented and coached in lifestyle choices that improve metabolic health. This is the problem. This is the issue that arises, because even the discussion about, well, what are the proper lifestyle choices that improve metabolic health? There's controversy over that. Like, we don't even have a consensus that fasting for longer periods is the right thing to do, or the ketogenic diet could be a powerful tool for someone to do. And there's suppression on YouTube of getting your information for freaking keto. Dr. Berg used to be the #1 keto guy in fasting, and now he's getting suppressed, and he talks about that. Anyways, I don't want to delve too much into the problems here, but look, for us, it's simple. We believe, like my clinic, myself, that these are powerful tools that open up a door that is necessary to be opened. But guess what? The goal is still a mile, right? But to even get that mile started, you need the door opened. And I think for a lot of people out there, they are trying to push through that door and they can't, because you want to call it a disease, you want to call it weight maintenance resistance, you want to call it a condition, it's arbitrary, right? Something is there keeping the door closed. And I think it's a lot of things. These medications open up the door. But if you don't want to fall on your face and be shoved out that room and have that door slammed back on your face again, over and over and over with all the times you've lost and regained weight, then you need to rely on something else after the door was open for you. And I'm here to tell you that it's these categories: better nutritional approaches, lots of fasting, lots of weightlifting and adequate protein intake, lots of sunlight exposure, respecting your sleep and trying to optimize that as best as you can, handling your stress levels, addressing inflammation issues when they arise, or doing some sort of chronic inflammatory maintenance, and being on a good supplement protocol, right? And I know I'm making that sound really easy, and it's not, right? I live this lifestyle. I've helped thousands of people achieve a lifestyle like this, but it's not something we can do overnight, which is why all the information I have is basically free and available to people between my book that you can get on Amazon or all the videos I make on YouTube. But it takes time, because
The coaching that I do is working with people on either a small group or even one-on-one to find the best sustainable approach for them, because you don't have to do all of those things to the level that I do. You could, and I hope that that's what you strive for, but we all have our own lives and stress levels and barriers, and a lot of us are just trying to get by. And we are going to put some amount of effort towards this. And so where my coaching comes in is to help people find a sustainable amount of these things that they need to be doing so that they can achieve weight loss, wean off the medications if that's what they desire, and maintain health. And the environment and the community is freaking awesome. And I absolutely love what I do, guys. If you guys are curious, you want to schedule a consultation with our team, we have many different coaching programs. We can prescribe the medications all across the country. We work with powerful peptides too as well. I think the peptides like growth hormone peptides and all these other options that exist out there to complement your GLP-1 medications can make a big difference as well. If you guys are curious about any of that, how we have such a high level of success, in the description to this video, we're going to link. You can either get the free guide or you can actually schedule a consultation and take a step forward towards achieving optimal health. If you guys enjoyed this video, please check this one out here, GLP-1 Realities. This was an interview that I did on a recent podcast where we talked about the program, but more importantly, we talked about these GLP-1 medications and all the implications that we need to think about in terms of using them as a tool like we discussed in this video. Take care, guys, and we'll see you later.